and this is I find that in Jharkhand areas, can we use an insulin storage device from RSSDI? And sometimes even the exercise doing, what we are telling your patient, go and do exercise. Do we need to teach such persons? What are the exercise types? This is aerobic is important or resistance is, they are already doing that. Even that these entities are not diabetic gestures. They are dancing other things. And all then you go for the all Jocelyn course, the diabetics who knows the most, lives the longest. And it is better to discuss how far you have walked than how little you have eaten. And well-trained nurse is of more value than a patient doctor, remember. So these are how things are changing. So what has not changed from bending solution to the time in range is the 225 vision of longevity for diabetics. I'm not going details, but this is a very, very exciting field to discuss how the sleep, the circadian rhythm, the sunlight exposure, the nature and social connection, even the grounding, personalized diet, vegetables, using genetic data, exercise regimes, meditation, mindfulness, lots of things are happening. And whole problem is what? You are taking more and more food, and you are not expanding that, not going to burn that, and then there are oversupply and the undersupply. This is the main reason of problem in today in diabetes. I will end here with that. Think also about the endocrine disruptors, then increase the telomerase, then the gut microbiota, and always show this slide to your school children that how these diabetic superfoods can protect, and we are not propagating this one, how the physical activity can do, what Surya Namaskara can do, and other things. With last slide, that precision diabetes based on genetic testing is a new concept for diabetologists. Genetics is not a part of routine clinical training at present. Traditionally, the specialty of diabetes emphasizes a best treatment rather than diagnosis, and so with that, precision message in diabetes is very, very important. And thank you very much that this was a disclosure from the ADA. If we do not know what causes type 1 diabetes, and we do not know at present what causes type 2 diabetes. Thank you very much. Thank you for inviting me. Thank you.
Thank you, Peg. How diabetes care has evolved over the years from Benedict solution to precision medicine. And I particularly like that one slide which you projected when you stressed upon the importance of understanding precision medicine, that 80% of our treatment is going as waste.
Yeah.
And how we have to move towards precision and personalized medicine to correct ourselves. Thank you for that excellent lecture, sir. So we'd like to join you on the stage. And next, we'll have discussion at the end of the session. Next, I would like to call upon our senior physician from Chennai, Dr. S.S. Lakshmanan, sir, who is a senior consultant physician, a very knowledgeable academician, and with more than 5 decades of clinical practice. He has been there in all academic forums to teach us about how on the topic case-based discussion on young diabetes. So over to you, Dr. Lakshman, sir.
Thank you, Dr. Dharmarajan. I present a very, very nice case, very interesting case of a very, very young fellow diabetic. I treated about 1 month back. He's a 13-year-old school student. He's a pure vegetarian Marwadi boy, was admitted with a high fever, abdominal pain, continuous vomiting of 3 days duration. He is a known case of type 1 diabetes on basal bolus insulin for the past 2 years. He was evaluated for abdominal pain in the year 2023, and he was found to have a hydronephrosis of the left kidney with elevated blood sugar of more than 600 in a corporate hospital. So they shifted the patient to a diabetes specialty hospital for sugar control before surgery. He was treated with insulin therapy and was investigated and diagnosed there as a type 1 diabetes. The previous hospital 2023, the A1C on admission was 17.5%, and the fasting C-peptide was negligible. The postprandial stimulation has just give 0.2 picomoles of C-peptide. GAD antibody was negative in the hospital where he was treated on the year 2023. The diagnosis made in the hospital was the diabetic ketosis with type 1 diabetes. He was started on basal bolus insulin of the insulin R 15 units 3 times a day and 25 units of the glargine insulin at bedtime. After 5 days, it was not sufficient. The insulin was escalated to 18, 20, 18 of short-acting insulin and the 25 of the glargine insulin. He made him fit for surgery. He went back to the corporate hospital where he underwent a left kidney pyeloplasty with the basal bolus insulin coverage and was stented. The stent came out within 3 months' time. The repeat stenting was done after 3 months again. Now, after 2 years, he presented to my hospital with a diabetic ketoacidosis with a severe urosepsis. He was febrile, toxic, he was extremely dehydrated, the pulse was 132, respiratory rate was slightly hurried. Very, very lean boy. He was BMI was less than 18, weight was 36 kg. Abdomen showed a severe left loin tenderness, no markers of insulin resistance. He has given a history, the operator for left congenital hydronephrosis and DJ stented 2 years back. There is no family history of diabetes. Random sugar was 620, A1C was 16.8. Urine were densely have ketones with a lot of pus cells and RBCs. His USCR was positive, urea was 56, creatinine 1.4. He had hyponatremia of 128, sodium, potassium was 5.4 and chloride 98. LFT was normal. You can see the sepsis, the total count was 32,000 with a polymass of 84 and the CRP was 130 milligrams. Chest was normal, EC showed a tachycardia, echo is no LV dysfunction. Scan abdomen showed a residual hydronephrosis left kidney with a severe perinephric fat standing, suggesting acute pyelonephritis. Serum hydroxybutyrate was positive. The diagnosis was diabetic ketosis with the UTI, with the pyelonephritis, with the type 1 diabetes. Shifted to ICCU. He needed, we started on IV insulin therapy. He needed about 5 to 8 units of IV insulin every hour to almost 150 units per day to keep the blood sugar less than 180. Given meropenem, saline, standard care for diabetes ketosis in ICU, the RFT became normal in 3 days' time. After shifting to the ward, he needed the 5-ASP insulin, the very short-acting insulin, 18 units 3 times a day, and the Tresiba, the Degludec insulin at 30 units at bedtime, just to keep the blood sugar between 180 to 240. He was advised insulin pump by me. The parents were not willing. It was very difficult to control the blood sugar with the below 180 milligrams. Now the problems in hand is that the patient has got a sugar of more than 600 4 times, diabetic ketosis 3 times, pyeloplasty left kidney once, DJ stenting was twice, recurrent UTI. He needed a very large dose of insulin, still the sugar not under control. Very pathetic looking boy, BMI of 18, weight of 36. The pump is the only solution. Are we missing the diagnosis or the both sides of the metro train looks similar? After 1 month, I again wanted to check the GAD antibodies and the C-peptide levels. Again, the GAD antibody was negative. Probably it belongs to a non-GAD antibody positive type 1 diabetes. C-peptide, again, the fasting was 0.3 nanogram and the stimulated was 0.8 nanogram. I don't, there is stimulus that the beta cells have, some living beta cells. We are puzzled, unsure, is a whole family were reluctant to get the patient on insulin, so much of insulin. I went back to the classification of type 1 diabetes. whether we have the same type 1 diabetes or different type 1. We have this boy, classically looking, ketosis prone, malnourished boy, type 2 diabetes. We know the specific types of diabetes. I have had shown you last, I think, presentation, a young fellow who was treated for 3 years as a type 2 diabetes. On the 4th year, we found out the boy had a Cushing syndrome. So please see that the secondary types of diabetes not to be ruled out by any means. It's not a GDM. There's a condition called type 5 diabetes. I was attending the Bangkok IDF April 8th, 2025. They reported a first case in 1955, BMI less than 19, very high blood glucose. They always need insulin, but usually they don't develop ketonuria, in contrast to my case. So whether my case belongs to a type 5 diabetes. This is a type 5 diabetes. I sent the sample of the boy, informing the parents that I'm trying my level best for a very precision diagnosis, and I waited for 8 weeks. The results came. Anyone want to discuss this case before I disclose the diagnosis? Chairman, audience. I think some of you would have heard this case before. Okay, I presented once or twice in a forum. Why? Yeah, I think there's a good diagnosis. I think the results came. The results came after 2 months. It took 8 weeks for the genetic studies to make a diagnosis. Dr. Mohan wrote a letter, congratulations on picking a case of HNF beta MODY, the MODY 5. The MODY 5. But they cautioned me that the MODY 5 is exactly like type 1 diabetes. Most of them require insulin. The Tattersall-Pajan's criteria, the one which gave a clue that there are 3 generations of people with the diabetes in the family, early onset, non-insulin dependence, absence of obesity, and they classically given absence of diabetic ketoacidosis. Probably the time where they had a Bajans and Tattersall, there were only type 2 and type 3, the MODY type 2, type 3. They do not go for the ketoacidosis. That was the one MODY 5. As you could see here, the defect is in the HNF1 beta and the severe kidney disease, pancreatic hyperplasia, and any female genital organ abnormalities. I think the message is very clear to you. Somebody presents with a type 1 diabetes like picture with a renal abnormality. That's the one. The organ which is affected is kidney. More than 90%. Please think of MODY 5. The common MODY, what you get in your practice is the MODY 3 and MODY 2. MODY 2 is the glucokinase deficiency. HNF-A deficiency is the MODY 3. Of course, the syndrome is called the RCAD syndrome. I think there was a mention on the floor that whenever you have a renal cyst or and diabetes, it's called the RCAD syndrome. That's the gene which is carrying that MODY 5. 17q, which is the focus. This is called monogenic diabetes. MODY 5, the HNF beta gene and the chromosome 17q. The first case was actually reported in the 1997 in the Japanese family. HNF1 beta is encoded by the human transcription factor 2 gene. And this variety of organs it is expressed, including the kidney, pancreas, genital. That's why they are always present with an abnormality of an other organ, either a kidney or a genitourinary system. And the maturity onset of diabetes, now we have the 15 subtypes. There are 14, I think 15 was reported by Dr. Mohan, among which the MODY 5 accounts less than 5%, and it has got number of extra pancreatic manifestations. Type 1 diabetes, and MODY share similarities in the early onset, potential for misdiagnosis with type 1 diabetes, and the ability to cause similar diabetes-related complications. MODY 5 always require insulin. Then how did they treat this case? As I told you, this is a case called RCAT syndrome. I went through the pathophysiology of the HNF1 beta associated MODY. They mentioned that there is a pancreas still working. The pancreatic hyperplasia resulting in beta cell hyperplasia results in decreased insulin secretion and release. But there's an increased hepatic insulin resistance which plays a major role in the development of diabetes. So the severity of the pancreatic hyperplasia determines the severity of the hyperglycemia and possibility of ketoacidosis at early presentation. So possible mechanism of MODY 5 include insulin secretion defect, insulin resistance, and abnormal glucose sensing mechanisms. So always I said somebody is even for a transplant, patients posted for type 1 diabetes, please rule out that the patient does not have a MODY 5. There's a case report from the MODY 5 in the Indian literature. A diagnosis more often missed than made. That is a IGM case report. Of course, I'm writing this for our Tamilnadu API journal. Today I met Dr. Vijay. He said it has been accepted for publication. So despite being a rare case, MODY is underdiagnosed and often treated as a type 1 diabetes. With regards to treatment options also I went through, they say sulfonylurea can be used as a first choice in MODY 5 because they have still some working beta cells. Its efficacy is often less in MODY 5. Patients often require early insulin therapy. I took a chance. I started this guy on glycoside, metformin, the dimicron 30 milligrams MR twice daily, pioglitazone 15 milligrams, metformin to break the insulin resistance, and I also gave him the Tresiba insulin at 15 units at bedtime. To a surprise, within about 3 months' time, this guy put on 10 kilograms of weight. The A1C reduced to 6.8 from 16.8. The fasting sugar came to 104 and the PP sugar came to 164. Absolutely, the infection in the urine has disappeared. There's no perinephric fat around the left kidney. There's a guy who came actually about 15 days back to now he's 56 kilograms. He was 36. Now he's 56 kilograms. Still now the A1C is maintaining to 6.8. I don't know how long it's going to work. I think I told him to have a nice diet control, do a lot of exercise. I think primarily breaking his insulin resistance, though he doesn't have insulin resistant markers in the external appearance. I think it's again very important carry a message that the cases which mimics like a type 1 diabetes where we have a horrid end, patient requiring so much of insulin, 100 to 120 units of insulin every day, and now we are shifted back to normal. Now he is studying about 7th standard in a school. Thank you. I think I'm happy to welcome any questions from the floor. Thank you very much. Thank you.
Case description now. If there are questions from the floor, Shanmali sir, yeah.
Yeah, it affects both exocrine as well as endocrine cells. With reference to endocrine cells, both alpha and beta cells.
He never had any exocrine deficiency of the pancreas. There's no exocrine deficiency has been reported in. It's only beta cell hyperplasia, not pancreatic hyperplasia.
Because it was mentioned as
okay, sorry.
pancreatic hyperplasia.
Okay.
So only beta cell.
Yeah.
So that means intact alpha cell.
Yeah.
That would have caused hyperglycemia and ketosis. As long as the glucagon secretion is there, definitely in the presence.
There was an option by Dr. Pannirselvam that why didn't you give DPP4 instead of sulfonylurea? He said he will suppress the alpha cells.
Thank you, sir.
As we approach analysis, before you got the genetic test, now you got the type. Before that stage, can we think is a form of mitochondrial diabetes at this stage? where GAD antibody is negative. It also has got an abnormal genetic marker.
No, I didn't think of mitochondrial because normally this comes in genetic form of diabetes where they have all other manifestations of the congenital problems. I think the boy is quite healthy to look at to make a diagnosis of mitochondrial diabetes. I think it's ruled out.
Yes.
Clinically it's ruled out.
Right, thank you.
Thank you very much.
Thank you. So thank you, Dr. A.K. Singh, for that excellent lecture and the case discussion. And the lesson that we learn is that don't take the diagnosis of type 1 diabetes on its face value, and go ahead and investigate so that you clinch the diagnosis. Thank you, sir.
Thank you. Thank you.
We'll move on to the next session.
Thank you, chairpersons and speakers.
Vishwanathan oration. RSSDI Tamilnadu chapter with great pride honors Dr. A.G. Unnikrishnan, a distinguished endocrinologist, visionary leader and passionate educator, with the Professor M. Vishwanathan oration at TRAC 2025. Dr. Unnikrishnan serves as CEO and endocrinologist at the Chalaram Diabetes Institute, Pune, where he also heads patient care, research and education. With over 25 years of experience in endocrinology and more than 230 indexed publications, his contributions span pioneering clinical research, impactful public health initiatives and transformative medical education. A former faculty member at CMC Vellore, Banaras Hindu University and Amrita Institute of Medical Sciences, Dr. Unnikrishnan has trained generations of physicians and endocrinologists. His leadership has guided major collaborative studies, including the Indian Pancreatitis Study Group and the MEDI study on early onset diabetes in India. He has been principal investigator in numerous national and multinational clinical trials, shaping diabetes and endocrine care in India and beyond. Under his stewardship, Chalaram Diabetes Institute has become a hub for excellence in clinical care, research and capacity building, with landmark initiatives such as the ACMDC and CCMTD certificate courses, rural diabetes outreach programs serving over 900 villages, and innovative e-learning modules accredited internationally. His illustrious career is adorned with numerous accolades, including the Professor Sam G.P. Moses oration, Dr. C. Munichodappa oration, P. Kesavdev oration, MGM Diabetes oration, and the Dr. Mohan's International Diabetes Update Gold Medal oration. Recognized for excellence in diabetes technology, patient care and education, Dr. Unnikrishnan has been honored by prestigious national bodies and state governments alike. Beyond his professional achievements, Dr. Unnikrishnan is known for his clarity of thought, commitment to ethical practice, and ability to bridge science with compassionate care, values that resonate deeply with the legacy of Professor M. Vishwanathan. In recognition of his outstanding contributions to endocrinology, diabetology, medical education, and public health, the Tamilnadu chapter of RSSDI is privileged to confer upon Dr. A.G. Unnikrishnan the Professor M. Vishwanathan oration at TRAC 2025.
Thank you, Dr. Dharmarajan. And Dr. Balamurugan. Okay, Dr. Giri, to kindly hand over the citation. Dr. Balamurugan to adorn the shawl on the speaker. Dr. Dharmarajan to give the memento. Thank you, gentlemen. Over to Dr. Unnikrishnan for the oration lecture.
Thank the entire team of Tamil Nadu RSSDI for choosing me and for this oration, Professor M. Vishwanathan oration. I am touched and moved, and the greatest gifts that we as doctors get are the blessings that we have from our patients and more importantly from our peers. So the award given to me by medical colleagues is at the highest of the high honors, and this is one of the most important days in my life to receive this oration. And whenever I come to Tamil Nadu and Coimbatore, I find I am with friends and well-wishers and the positivity is huge. I thank Dr. Balmurugan, Dr. Rajendran, the entire Coimbatore team, RSSDI team for honoring me and choosing me for this oration, and also to Dr. Mohan as well, and Dr. Vishwanathan and the rest of the family, Dr. Vijay Vishwanathan and the rest of the family. Of course, it is very humbling to stand even in the oration name of such a great person like Dr. Vishwanathan, Dr. M. Vishwanathan, who is a pride of India. And I will, of course, begin my oration by invoking his blessings. My oration is going to touch about 3 areas. The first is managing diabetes in India. There are many challenges. I'm not talking about urban big hospitals managing diabetes. I'm talking about rural India. There are huge challenges. And then I will talk about our experience in the mobile diabetes community program that we did, how we understood the disease from that viewpoint of the villages. And third, understanding was not enough, how we tried to forge a way forward to help and make sure that those who are most in need of this get it in an appropriate manner. So there are rural disparities, regional disparities in the prevalence of diabetes in India. If you will see, the prevalence is very high in some parts, much less in other parts. And if you see the status of diabetes care in our country, the average HbA1c when you see patients is 8.9, and that is probably not reflective, because in many parts of India diabetes is not tested, it is not diagnosed, it cannot be treated because of affordability and accessibility to cost. Now, these are some pictures from our mobile diabetes clinic program. It's a very unique program. You can see this gentleman. When I went to the mobile diabetes clinic, I found this gentleman. If you see, he is waiting for his retina checkup in the mobile diabetes clinic. Of course, our mobile diabetes clinic is equipped with biotissuemetry, ABI, and this is me standing, but the team looks after it. And this gentleman, you can see he has a diabetic foot. Several of his toes are amputated, but he is actually having no access to foot care. This is in remote rural India, mountainous regions. When I visited these areas, sometimes 6 or 7 villages will have one medical shop. They will have one tablet for diabetes and one injection for diabetes, nothing else. And there is no diet advice, no exercise advice. Even the doctors are very few in those areas. So he has put a net and tied it up so that the whole leg is offloaded by himself in his own method. Nobody has told him how to take care. He is working on this. And this is Dr. Dhore, who designed our mobile clinic program. What we do is, our mobile clinic, which has a medical officer, a couple of nurses and equipments, stationed in a large village. In the morning they go to the small village, evening they come back to the large village, and when one big village and all the small villages are over, which takes about a month or 2, our team will migrate to the next hub and spoke. So we did this hub and spoke model, and you see the feet, and if you see the problem with diabetes in India, known cases are only 50%. 50% is unknown. In the rural mobile diabetes clinic, of course, I didn't go and serve there, but I went to oversee and supervise it. I found that many people have never been tested. Many people's HbA1c is high. Many people are not even poor, but they have never undergone test. So there is a problem of access, awareness, trained personnel, and cost. So one way to look at it is, take the entire population, screen everybody for diabetes. Don't leave anybody, take everybody. That's a big logistical challenge. The other way to look at it is, take the population, take the high risk people, and then screen them for diabetes. Those are the low hanging fruits. If you take high risk people and then screen them, then you may get more cases from the community. And that's what we did. And of course, women have another problem, because women are, in our country, women are not given care on time. Women often are the last to take care in health activities. They are the last to get health care. They are last to get guideline modulated or mandated care. And they go through puberty, adulthood, menopause and old age. And this is of course a mobile diabetes clinic they take care. And if you see abdominal obesity in rural women, this is the paper we published, and we found that whether you look at men or women,